Now, respiratory tract infections are infectious diseases involving the respiratory tract. An infection of this type is usually further classified as upper respiratory tract infection or a lower respiratory tract infection. Now, the upper respiratory tract infection include infection in the nose, nasal cavity and sinuses, pharynx, larynx, and trachea, while the lower respiratory tract infection include lungs, airway, both bronchi and bronchiole, and air sacs, the alveoli. Now let us start with upper respiratory tract infections. Now, the common cold, also known as rhinopharyngitis, is an inflammation of the nails, pharynx, hypopharynx, uvula, and tonsil. The common cold account for approximately 22 million missed days of school and 20 million absences of work, including parent taking away from work while caring for ill children. Now, common cold can be caused by a variety of viruses. The most common group are the rhinoviruses, and they are responsible for up to 80% of the common cold. And as you all are aware, rhinoviruses include more than 100 serotypes, and so it's not unusual to have recurrent infection with various types of rhinoviruses. Now, other viruses which may cause common cold include the coronavirus viruses, the respiratory syncytial viruses, the parainfluenza, and adenovirus. Now, healthy children under the age of 6 will have an average of 6 to 8 colds per year. And what happen usually that this episode of cold usually come during the winter time, and it's around between September through April. So the child will come every month with one episode of cold, which really created a lot of concern for parents. Their concern is whether their children are having a sign of immunodeficiency, or this frequent has to do with their immune system. And what makes it a little bit more complicated, if these children, they have also allergies, such as allergic rhinitis or asthma, what happened that the virus trigger their underlying allergic diseases. So what happened? The illness will start with a common cold, and which may take 1 week to 10 days. And when the patient, his cold resolve, he will carry on with exacerbation of his underlying allergy. So the parent usually complain that their child every month will have a prolonged cold, and all what we need to do is just to explain that this is not an abnormal. Now, the sign and symptom of cold, it's usually began 1 or 2 days after exposure. And the most prominent symptom in children include fever, which may reach 38. In addition, they may have sore throat, cough. Small children, they have irritability, difficulty to sleep. Now, transmission of the common cold viruses can be by 3 mechanisms. Hand contact, self-inoculation of one on conjunctiva or nasal mucosa after touching person or object contaminated with cold. What happened, you may enter a room and somebody was before you in that room, he was sneezing and coughing. He contaminated the surface there. If you touch the contaminated surface and then you rub your nose or your eye, the virus can get an access, and then you will have cold. And you have to keep in mind that the majority of cold also can be transmitted with hand contact. Common cold viruses may remain viable on human skin at least 2 hours. And some people, they may sneeze, they put their hand over their nose, then they forget, they go and shake hand, and they can be a source for spreading the infection. Now, the diagnosis is a clinical diagnosis, and complications do occur and include otitis media, sinusitis, asthma exacerbation, and even pneumonia. Now, this slide shows the symptom profile of common cold in children. The colored lines represent various symptoms associated with common cold. So in infant and children, the symptom usually peak within 2 to 4 days, and they gradually improve, and most of the time the common cold resolve by day 10. Now, differential diagnosis, it may include common cold, influenza, and allergy. And although the flu and common cold are both respiratory illnesses and they are caused by different viruses, however, these two types of illness have similar flu-like symptoms. And sometimes really at the beginning, it's very difficult to be differentiated based on symptom alone. However, the influenza virus is usually will present with more severe symptoms in comparison to common cold. These children will have very high fever, they have malaise, fatigue, and weakness, and their symptom actually may be really quite severe during the first week. Now, in terms of allergy, as I mentioned before, the viruses causing common cold or influenza may exacerbate allergic rhinitis. However, children with allergy, they don't usually have fever and they don't have severe symptoms. Now, the treatment of, as you know, common cold is self-limited illness. So our advices for caregiver is really just to give antipyretic in case of fever, hydration, and for nasal congestion, we use just saline nose drop. And antiviral is usually not recommended. And I think the only exception for influenza that sometimes you may need to use antiviral if the child is sick. Now, coming to medication available over the counter, in particular, cold medications, the US FDA issued a safe warning about using this medication routinely in children less than 6 years. Now, you may ask, what about older children? Now, I can tell you we don't have an evidence-based data to support, again, using this medication. However, when this issue was discussed within the American Academy of Pediatrics, there were some consensus of some experts that maybe this medication may help in older children. So you may consider it in children 12 years and above. But again, this is based on voting and consensus from expert group. Now, please keep in your mind that antibiotics are not useful for treating cold in children because, as you know, they only kill bacteria, not viruses, and the inappropriate use of antibiotic is really a major factor in causing bacteria to become resistant to antibiotics that are previously able to kill them. So please not use antibiotic for common cold. Now, if you go to ambulatory care or private practice, sometime when children presented with cold, although the physician his probably diagnosis or discussion with the parent that this is a simple common cold. However, some of them, they end giving antibiotic. And when you ask them why you are giving this, and they will tell the parent that although it's a common cold, but this may turn at any time to a secondary bacterial infection. So take this antibiotic. And this is really bad practices and should be discouraged. Now, moving to otitis media. Otitis media is the second most common disease of childhood. And what you see in this slide is the pathogenesis of otitis media. So you have a normal ear and an ear with otitis media. So the pathogenesis of acute otitis media generally involve the following sequence of events. Most of the time, the child will have an antecedent upper respiratory tract infection. The event usually results in inflammation and edema in the respiratory mucosa of the nose, nasopharynx, and Eustachian tube. So this will usually followed by obstruction of the isthmus, causing poor ventilation, and this will result in negative middle ear pressure. And this further lead to accumulation of secretion produced by middle ear mucosa, and the secretion have no egress and accumulate in the middle ear space. And as you know, viruses and bacteria which may colonize the upper respiratory tract may enter the middle ear via aspiration or reflux. And what happened that this will lead to microbial growth in the middle ear secretion, which result in the symptomatology of otitis media. Now, otitis media, as I mentioned, is a really quite common problem in pediatric. It's responsible for 24 million healthcare visits per year. And the illness also generates a significant social burden as indirect costs due to time loss from school and actually parents staying from children from their work. It was estimated that otitis media costs $2 to $3 billion annually in the US. Now, most cases of acute otitis media occurred in young children between the age of 6 to 24 months, and up to 80% of children, they will have their first otitis media in their first birthday. And actually, the majority, by 3 years, they will have one or more episodes. Now, in terms of risk factor, children younger than 2 years are physiologically predisposed to otitis media because their Eustachian tube are shorter and small in caliber and more horizontal in comparison to adults. Now, other risk factors include the age, as I mentioned, small children, also lack of breastfeeding, smoking, and air pollution. When it comes to pathogenesis or pathogens causing otitis media, now the majority of data on microbiology of acute otitis media has been documented by cultures of middle ear obtained fluid by laryngotomy. And as you can see here, the most common bacteria are Streptococcus pneumonia, followed by non-typable Haemophilus influenza and Moraxella catarrhalis. Now, group A strep and Staph aureus are less frequent causes of otitis media. Now, in terms of viruses or viruses causing upper respiratory tract infection, children may have actually co-infection with viral and bacteria. And by doing middle ear evaluation for the possibility of viruses using PCR, several viruses were detected, and these viruses include rhinovirus, RSV, and influenza virus. Now, accurate diagnosis of otitis media is very crucial. And this is really mainly to avoid the overuse of antibiotic and inviting antibiotic resistant. The American Academy of Pediatrics established evidence-based clinical practice guideline to provide recommendation for physician managing children between the age of 2 months to 12 years with uncomplicated otitis media. So if you want to diagnose, or the diagnosis of otitis media require having the following. Number one, the acute onset of signs and symptoms. And usually in older children, they suddenly complain of severe ear pain. However, when it comes for small infant, they may have just irritable sleep. So this is number one. Number two, you need to have the presence of middle ear effusion. And actually using the pneumatic otoscope, as you can see in this picture, will increase your ability to detect the presence of middle ear effusion. So what happens when you use the pneumatic otoscope, which help to determine the mobility of patient tympanic membrane in response to pressure changes, that you will find limited or absent mobility of the tympanic membrane, which indicated that you have fluid there, but also you may see a bulging of the tympanic membrane. Number three, you need to have sign and symptom of middle ear inflammation. And as you can see from these pictures, you have a distinct erythema of the tympanic membrane. So to make the diagnosis, you need to have these three together. Now, keep in mind that sometimes children may cry, and when you examine the ear, you see a little bit of redness, but definitely this is not otitis media, and you need to have these three important factors really to make a proper diagnosis. Now, we have to differentiate acute otitis media from otitis media with effusion. So otitis media with effusion, sometime a child coming to your practice, you examine the child totally asymptomatic, and you find some middle ear effusion. So the middle ear effusion, you don't see any sign of inflammation. And usually after otitis media, even uncomplicated, you may have persistent middle ear effusion for a few weeks. So, so if you have a child with middle ear effusion without sign of symptom of acute ear infection, you don't need to treat. Now, in terms of management, it's a very important really to recognize that otitis media is very painful. So pain management is a mainstay of treatment of otitis media in children, and pain is a very common feature in otitis media and really can quite severe. So we use paracetamol or ibuprofen for pain or fever, and sometimes you may use topical analgesic drop. Now, it's a very important that, as you know, when you start your antibiotic, it needs maybe 24 to 48 hours to work. During this time, the child may complain from ear pain. So you may use these ear drop to decrease the pain, but you have to advise the parent in case their children complain of ear pain, they should not use it routinely in the future, because it may mask the pain of otitis media, which may lead to progression of otitis media and possible complication. Now, antibiotics are used routinely for the treatment of otitis media, and amoxicillin high dose, we use 80 to 90 milligram, is the drug of choice. So why use amoxicillin? Because simply it's a quite effective drug. It's a drug with a low cost. The taste is acceptable for children, and it's narrow range in terms of microbiologic coverage. We don't like to use wide spectrum antibiotic unnecessarily. However, if you have a child who came to you and during the history, you discover that he received antibiotic within the last 1 month, or at the same time, when you diagnose acute otitis media, you find in your examination that there is concurrent purulent conjunctivitis, which means that you may have a beta-lactam introducing organism, or the child is allergic to penicillin, then you may consider using augmentin. Now, when you talk about allergy to penicillin, you have to differentiate between IgE mediated, which is may lead to anaphylactic reaction, or non-IgE mediated. Non-IgE mediated, you can use the cephalosporin, you can use cefdinir or cefuroxime. However, if there is IgA mediated, then you want to move to use macrolide. What about observation? Actually, the American Academy of Pediatrics gave the option in particular for children 2 to 12 years with mild to moderate symptom, that you can defer your antibiotic up to maybe 72 hours. However, you need to have follow-up with that patient. Now, one common problem, again, in a private practice, that they decided for observation, however, they give the antibiotic to the parent. So instead of having follow-up within 72 hours and re-examine the child with persistent symptom, they ask the parent to decide. So they will tell the parent, okay, this is the antibiotic. If your child did not improve within 2 to 3 days, then you can start the antibiotic by yourself. So they don't tell the parent about duration of the antibiotic and so on. And again, this is another bad practice. Generally speaking, the duration for treatment for children less than 2 years is up to 10 days. However, in older children, the duration can be 5 to 7 days. Now, immunization is really very important, and it helps to decrease some of the infection or some of the pathogens causing otitis media. As you know, influenza virus or influenza infection can be associated with also otitis media of viral nature. The use of influenza vaccine should decrease influenza complicated with otitis media. The same apply with the pneumococcal vaccine. Now we have the 13-valent Prevnar vaccine. It's a conjugated pneumococcal vaccine, and studies have shown that the vaccine should prevent serotype within the vaccine that can cause otitis media. Now, moving to tonsillitis or pharyngeal tonsillitis. So by definition, tonsillitis is an inflammation of the pharyngeal tonsil. In young children, it's usually viral of origin. However, in older children, about 1/3 of these children, they may have group A beta hemolytic strep. These children usually present with fever, sore throat. They have dysphagia, and they have tender anterior cervical lymph node. And again, when you look to the tonsil is quiet red, and you can see pus follicles. Now, if you want to confirm the diagnosis, you can do culture or you can do rapid antigen test. Rapid antigen test can be very useful. The test has very high specificity, above 95%. But keep in mind, whenever you do the throat swab, you need to rub the tonsil, not just to take it from just the mouth secretion. So rubbing the tonsil will improve your ability to have an accurate. So if you do the rapid antigen test, if it's positive, you make your diagnosis. Now, rapid antigen test is usually available in many private practice. However, if the rapid antigen test is negative, the child continue to have symptom, then you may need to do culture. So despite all the resistance to antibiotic, penicillin remains the drug of choice for treating group A strep pharyngitis. You can use penicillin or amoxicillin. The question is why we treat tonsillitis, group A strep, group A beta strep tonsillitis, simply because this will help to prevent the sequelae of group A strep tonsillitis, such as rheumatic fever. It also prevents the complication, and also it will help to decrease the transmission of the bacteria between family members. So this is the reason we treat. Now, if you don't have facility or you don't have access to do rapid diagnosis or culture, the center criteria was created to help physicians to increase their ability to diagnose group A strep tonsillitis. It was initially made for adults, then modified for children. So the criteria include the presence of tonsillar exudate, tender anterior lymph node, fever, absence of cold symptom, and can be used for children less than 15 years. So if you have 4 out of 5 center criteria, the positive predictive value can up to 6%, and the absence of 3 or 4 the negative predictor value of 80%. So the center criteria can help you for your ability to make the clinical diagnosis of bacterial tonsillitis or group A tonsillitis. Now, moving to sinusitis, by definition, is an infection of paranasal sinus. This huge infection can occur after cold or after allergic inflammation. Sinusitis is classified as acute, subacute, or chronic, and this all depend on the duration of symptoms. So acute sinusitis, 30 days, subacute, 30 to 90 days, and chronic is 90 days. Now, there are four sinuses in children. The ethmoid sinus, located around the area of the bridge of the nose, the sinus present at birth and continues to grow until puberty. And then you have the maxillary sinus, located around the area of the cheek. The sinus is also present at birth and continues to grow until puberty. The frontal sinuses located in the forehead, this sinus does not develop until the age of 7 years. And the sphenoid sinus located deep in the face, behind the nose, this sinus does not fully develop until adolescent, around 8 to 10 years. And keep in mind, the most common involved sinuses in children are the ethmoid and maxillary sinus. Now, in terms of bacteria, it's easy for you to remember that the same pathogens, bacterial pathogens, causing otitis media are the same causing sinusitis. Now, again, to differentiate between viral versus bacterial sinusitis, the Infectious Disease Society of America established a guideline which help physicians to make this differentiation. So you have three scenarios. The first scenario, which is the most common, you have a child who present to you with cold that really continue beyond 14 days, and during the examination you may have post-nasal discharge, and this child continue to be sick and did not improve. Or you have a child with acute presentation, very high fever, post-purulent discharge. And in older children, when you tap the sinus, you have a local pain. Some children may have a few days of cold, and suddenly the symptom change with increased fevers, headache, which last for 5 to 6 days. So you have three scenarios to help you to differentiate whether this is a bacterial or viral. Now, some other symptom, nasal congestion. You may have, some children may have low-grade fever, and you may have another focus on the same patient, such as otitis media. Older children, they have headache. Small children, they usually have irritability. Now, moving to chronic sinusitis, here the pathogens are different from the one causing acute sinusitis. So you start seeing anaerobic, you can see also some gram-negative organism. Now, the presentation, usually we follow the IDSA criteria. Now, there is a lot of debate and some misinformation about imaging. So sinus X-ray or even CT scan should not be done routinely in children, because any child who is cold, if you do whether sinus X-ray or CT scan, it will be abnormal. So CT scan is usually done mainly for patient with recurrent sinusitis or you suspected complication, which do occur, as you can see in the picture for this child. This child had acute sinusitis, complicated with orbital cellulitis. Some children actually, we had actually one child recently. It's a 10 years old healthy child who developed acute maxillary sinusitis. It was progressed to preseptal cellulitis. It's further complicated with periosteal abscess and epidural abscess. So this is very rare complication, but it can occur. Treatment is with antibiotic. Augmentin is the drug of choice. Now moving to lower respiratory tract infection, as you know, bronchiolitis by definition is an acute infectious inflammation of the lower respiratory tract. Most infants are infected during the first year of life, and virtually all have been infected at least once by the second birthday. Keep in mind, please, bronchiolitis is almost always caused by virus. Bronchiolitis is not caused by bacteria. Now, RSV is the leading virus causing bronchiolitis, and RSV usually cause regular outbreak, which lasts 2 to 3 months. It usually began in late fall or winter. In the kingdom, it's usually occur between October to March, and you will see some variation in various countries in terms of seasonality. Now, other viruses that may cause bronchiolitis include the parainfluenza, the human metapneumovirus, rhinoviruses, and bochovirus. Now, factors to increase the risk of severe bronchiolitis include extreme prematurity, cyanotic or complicated congenital heart disease, actually especially condition associated with pulmonary hypertension, children also with chronic lung disease, and also children with immunodeficiency. Now, the clinical feature, the typical presentation, you have an infant who initially developed upper tract infection. However, symptoms progress over 3 to 6 days. He developed respiratory distress manifested by tachypnea. Prolonged, when you examine the child, you will hear bilateral expiratory wheezing. These infants are at risk to have dehydration. They usually have poor oral intake. Sometimes they may have another focus. And the small infant actually may present with apnea and cyanosis. Now, the diagnosis most of the time is clinically. However, if you do chest X-ray, which is not done routinely, you will see more or less hyperinflammation and some air bronchogram. In all days, we usually do rapid direct or indirect immunofluorescent. Now we do multiplex PCR, and there is various viruses and various kits used. We don't do culture. RSV is a fastidious virus, which is difficult to grow in cell culture. So the treatment mainly is oxygen. Pulse oximetry is needed. If oxygen drops 92%, you have to give oxygen. Hydration is very crucial. Now, the issue of bronchodilator really should not be used routinely in bronchiolitis. Although if you go to emergency room, you see some physician using bronchodilator and even steroid, which should never use. But when you ask them, they said they felt that this is really quite severe. When they ask the parent about history of asthma, they told them that they have other children with asthma. So they're concerned that maybe this is the first presentation of moderate severe asthma, so they give bronchodilator and steroid. But really, bronchodilator steroid should not be given routinely. Now, palivizumab is a monoclonal antibody. It's used by injection. It is really reserved to prevent RSV in high-risk children. Now, moving to pneumonia. Pneumonia is an abnormal inflammatory condition of the lung, an abnormal alveolar filling with fluid. This fluid is usually consolidation and exudation, and this leads to compromised air exchange. And if not corrected, this may ultimately lead to hypoxic injury and death. Now, some authors defined pediatric community-acquired pneumonia using clinical criteria. However, others require to have radiologic evidence. And the WHO established a radiologic definition of pneumonia. You need to have a dense opacity that may be fluffy consolidation of a portion or a whole of a lobe or entire lung. containing air bronchogram and sometime associated pleural effusion. Now, keep in mind pneumonia is a leading cause of death in low-resource country in children less than 5 years. So we need to differentiate between community-acquired pneumonia and hospital-acquired pneumonia. I'm discussing community-acquired pneumonia in healthy children, not immunocompromised host. So community-acquired pneumonia, you need to have the presence of sign and symptom of pneumonia in healthy child who has been acquired from the community. While hospital-acquired pneumonia, you have a child in hospital, and while being in hospital, he developed pneumonia 48 to 70 hours from stay in hospital facility. As I mentioned, pneumonia is a leading cause of childhood death, particularly in low-resource country and sub-Saharan Africa. Pneumonia is responsible for 21% of deaths in small children. Actually, pneumonia killed more children than AIDS, measles, and malaria combined. So it's a really very serious disease in children. Now, pathogen implicated in pneumonia vary with age of the child, underlying patient-specific risk factor, immunization status, and seasonality. So whenever you came across any child with pneumonia, and in your mind, this is maybe bacterial pneumonia, keep in mind all these things that it may really give you a clue about the etiology. Now, Streptococcus pneumoniae is the single most common bacterial pathogen causing pneumonia in all children beyond the first few weeks of life, and it may be responsible for up to 20% or more, depending on the region. Then you have the Haemophilus influenza, and as you all aware, we have two types of Haemophilus influenza. We have influenza type B, which is invasive, which can cause not only pneumonia, bacteremia, and meningitis. However, Haemophilus influenza type B was totally eradicated from countries where the Haemophilus influenza type B vaccination was part of their national program. For instance, in Saudi Arabia, we don't see any Haemophilus type B because Haemophilus type B vaccine is part of our national immunization. However, in certain Arab countries or some countries in Africa, they still see some cases because the vaccine is only offered in private, not for the entire population. Now, the second Haemophilus influenza, it is a non-typable Haemophilus influenza, and there is a lot of debate whether non-typable Haemophilus influenza can cause pneumonia. However, when you look to some studies coming from sub-Saharan Africa, non-typable Haemophilus influenza was isolated from lung aspirate from sick children. However, when you look to these children, all these children, they are malnourished or they have HIV or some chronic disease. Now, when it comes to older children, keep in mind Mycoplasma pneumonia and Chlamydophila pneumonia. And there have been several reports about severe pneumonia caused by community-acquired MRSA. These children, they have the PVL or Pantone, Valentine, leukocidine exotoxin. This exotoxin causes leukocyte destruction and necrotizing pneumonia. Now, when viruses are common cause of pneumonia among toddler and preschooler, if you look to RSV is common in young children. And if you look to statistic shows that as many as 20 to 25% of infants with pneumonia who require hospitalization infected with RSV. This is followed by influenza type 3. Now, when it comes to adenovirus, we have around 52 serotypes. However, only seven types are responsible for severe pneumonia, and sometimes you will see adenovirus outbreak. And in terms of influenza, pneumonia actually is the most common complication in children hospitalized with influenza. Now, rhinoviruses, you remember we discussed it earlier, rhinoviruses are responsible for usually a common cold. However, there is more data which indicate that rhinovirus can be responsible for up to 30% for virus-related pneumonia. In particular, actually, we have seen not immunocompetent, but some immunocompromised patient requiring hospital admission and maybe ICU because of severe complication. Now, enterovirus D68, this is a re-emerging virus. It first reported in 1962. However, in 2014, was responsible for outbreak in several cities in the US. And also some cases of enterovirus D68 pneumonia. These children also developed acute flaccid myelitis. Now, I want you to pay attention for this group here of viruses. Now, human metapneumovirus, it's a virus. Initially, we thought that this is a novel virus. However, when they went back to a stored respiratory sample in the Netherlands, they discovered the virus was there for more than 20 years. However, we failed to diagnose this virus because the virus is difficult to grow in cell culture. And when we started using molecular technology, PCR, we managed to diagnose. Metapneumovirus can cause actually quite severe pneumonia requiring admission in healthy children. Now, moving to human coronavirus, we have two types of human coronavirus. We have non-pathogenic and pathogenic. The non-pathogenic viruses, and I'm sure when you work in our hospital and we do multiplex PCR, you see these viruses, 229 coronavirus, the Netherlands 63, OC43 coronavirus, and HK coronavirus or Hong Kong coronavirus. Now, these four viruses are responsible for also common cold, which we get every winter. And I can say about 15 to 20% of all recurrent common cold caused by one of these four viruses. Now, the SARS coronavirus, MERS coronavirus, SARS coronavirus 2, all these are pathogenic virus. Now, the SARS coronavirus, as you remember, it was very close or near pandemic. It occurred in November 2002, disappeared in July 2003. The civet cat in Hong Kong was the source for transmitting the virus. I think around 8,000 plus cases infected with 774 confirmed human deaths. Case fatality was low, around 9.6%. Then we have the MERS coronavirus, the Middle East Respiratory Syndrome, which was first actually identified in Saudi Arabia in 2012. The virus caused mild illness in children. However, it caused really severe illness in adults. In particular, if patient require admission to ICU and require ventilation, then the mortality rate can reach 60 or 70%. And currently, we have the SARS coronavirus pandemic, and currently the most prevalent variant is the Omicron variant, also known as B1529. What we know about this Omicron, that it's fast. Children also can be infected. In some studies from the UK, up to 20% increase in hospital admission for children. Now, the Omicron virus is different than the Delta virus. The Delta virus more attack the lower respiratory tract in terms of Omicron, usually called mild to moderate flu-like illness, and 1 in 10 children may have like pneumonia. The majority of children, small children, they have really high fever, cold-like symptom, and some of them, they have vomiting and diarrhea. Most patients, they did not require admission. Patient admitted actually mainly because of their primary disease, such as chronic lung disease, chronic heart disease, or immunocompromised status. Now, moving to human bocavirus, this is a virus which really is still a challenge in terms of pathogenicity. Human bocavirus, most of the time, is detected by PCR with other pathogenic virus. So you have a child with cough and maybe pneumonia, and you do the multiplex PCR, you see human bocavirus, but in addition, RSV, parainfluenza, or influenza. So this virus did not yet establish pathogenicity, and some of the children, they may have also some GI symptom. Now, determining the etiology of pneumonia can be challenging in children. However, the age of the patient can help you. If you are talking about neonate, you can think about bacteria which colonizing the genital tract or the delivery tract. You have these bacteria, group B strep in the lead. You may have some viruses. Chlamydia trachomatis with a sexually transmitted disease, it's really almost eradicated because of a good screening and early treatment of pregnant women. As you get older, you can see here from 1 month to even adolescent streptococcus pneumonia in the lead. For children 4 months to 5 years, you would see significant increase in viruses causing pneumonia. From 5 years, you have to keep in your mind the atypical mycoplasma and chlamydia pneumonia, and then in older children is the same. Keep in mind the atypical. It's a very important to keep in mind pertussis because we know that the vaccine are not optimal, and also mycobacteria, TB, and this is you can get it from the history of exposure. Now, in terms of symptom, when it comes to newborn with pneumonia, they usually have symptom a few hours after delivery. They have respiratory distress, but they don't usually have cough. And again, in your examination, you will find crackles. And if you do X-ray, you see ground glass appearance, bronchogram. Now, in older children, 1 month and above, cough is the most predominant symptom, presenting symptom, and quite really common. You may have respiratory distress. In older children, they may have chest pain. Sometimes they have also abdominal pain. And then you see more constitutional system in older children and adolescents. Now, physical examination is very important. The most important whenever you come across a child with pneumonia, you have to address hypoxia. You have to correct it early, and you have to pay attention for dehydration. Definitely, you will measure the fever, and also you examine for other focus. But tachypnea is the most sensitive and specific sign of radiologically confirmed pneumonia. Even the WHO actually suggested that tachypnea and retraction as the most accurate sign for pneumonia. As you know, in low resource country, they don't have access for imaging. So the WHO established criteria. So if you have a child 2 to 12 months, he came with tachypnea more than 50, then you can diagnose pneumonia without doing any radiologic studies. Other symptom, retraction, and as I mentioned, you have to look for if there is another focus. Now, we don't usually do lab in each patient. However, you can do CBC if you have leukocytosis. It's usually associated with pneumonia, especially if you have left shift. You can do any acute phase reactant, ASR, C-reactive protein, procalcitonin. The elevated serum procalcitonin concentration is more sensitive, but actually more sensitive and more specific than C-reactive protein. Blood culture is only positive 10 to 12%, but usually if you have a child who is sick and he requires admission, you have to do blood culture. Sputum, very difficult to collect in children. Sometimes you may need to do induced sputum. If you do it in older children, as you can see in these pictures, you have to first evaluate the sample that you need 10 epithelial cell. You look for white blood cell, and the gram stain here showed gram-positive cocci in chain, and the culture subsequently was positive for pneumococcus. Rapid viral testing, if you have a facility to do it, it will be useful in patient admitted to the hospital where you don't need to use antibiotic, but also for infection control. But the other test is not done routinely unless you have somebody who suspected maybe exposure to TB. They need to do PPD skin test. We do TB quantiferon, which is not sensitive in small children below 5 years. If you suspected a typical PCR is the method for choice for diagnosis, but you have to correlate it with the symptoms. So if I have a child admitted with pneumonia and I do my molecular test for mycoplasma or chlamydophilia and positive, then I can say this is a mycoplasma. However, the child totally asymptomatic, maybe an old infection. Please keep in mind, if you have child with pleural effusion, very important to tap and analyze the yield to recover the organism is really quite high. The management of pneumonia, as I mentioned, we use the age of the patient. This will give us some idea about what type of bacteria possible there, and we use empiric antibiotic. Now, if you look in the literature, there is various literature about what empiric antibiotic is used. However, generally speaking, if the child does not look that sick, you can use just really amoxicillin. As outpatient, in older children, you may use macrolide. However, if the child require admission, then you can, depend on the age, you can use ceftriaxone or you use third generation cephalosporin. If the child really quite sick, you need to keep in mind the community acquired MRSA. You may use vancomycin and clindamycin. Now, again, we usually don't admit all children coming with pneumonia. Is there a criteria? Yes, this is the criteria. You can see it in this slide. So children with moderate, severe pneumonia, in particular, if they have hypoxemia, they should be admitted. We admit small infant if you suspected pathogen increased virulence. And again, if the parent, they told you really we cannot cope with the child, he's not eating, he's not drinking, he's not sleeping, he's always irritable, it's better to admit. Vaccination actually quite good to prevent some pathogens which used to cause pneumonia. We talked about the HIV vaccine, conjugated pneumococcal vaccine. We don't rarely see measles, varicella, or pertussis pneumonia because of the vaccine. Influenza vaccine is really recommended as early as 6 months, and it will help to prevent influenza causing pneumonia. Palivizumab is reserved for high-risk children, and it prevents not only bronchiolitis, but also pneumonia. I will stop here. Thank you very much. Please let me know if you have any question.
No questions. Thank you, doctor.
Okay. يعطيكم العافية. I wish you a very productive and safe week. يعطيكم العافية. مع السلامة.
مع السلامة.